Can I start, Annette?
Yeah, all good.
Okay, cool. So we'll continue with the MCQs. So I've stopped at this, so we'll go from 431. Okay, what is incorrect in estimating the risk of endocarditis? Fallet's tetralogy, previous repaired septal defect, previous history of bacterial endocarditis, rheumatic heart disease in indigenous Australians, prosthetic cardiac valve. So we will give or we will consider risk of endocarditis in patients who are with this problem as well as this and this. Probably septal defect is something that I might not stress too much about. There is still a risk of endocarditis in septal defects, but if it is repaired more than 6 months ago, or if it is a very old defect, it should be fine. They might not get endocarditis. Next one. For urticaria, you will give antihistamines, adrenaline, steroids. So urticaria, very mild. I'll probably go with antihistamines. So like how I say, most conservative treatment is something that you should always consider before answering anything else. So for this case, it's urticaria. The conservative, the most mild treatment would be with antihistamines. Anything more than that is next level. Say the scenario says patient with urticaria, he tells you that antihistamines don't work for him, or some other reason, something like that, or they would have already been taking antihistamines and they were not working. Then what would you give? Then my second option would be to give steroids. Definitely not adrenaline. Adrenaline is for hypersensitive reaction, which is, more severe, like anaphylaxis. Adrenaline is not used for regular hypersensitivity reactions. The next one. What is incorrect about facial paralysis? Inability to blink, inability to smile, incorrect method, injecting LA into parotid gland, damage to facial nerve. What is incorrect about facial paralysis? I'm assuming the question is what is incorrect about transient facial paralysis. So facial paralysis can be Bell's palsy, which is more long term and all those things. Whereas transient facial paralysis will happen when you inject local anesthetic into parotid gland. So all these things are present, inability to blink, smile, incorrect method of local anesthetic, injecting LA into parotid gland. But as such, they might not be damage to the facial nerve. When there is a damage to the facial nerve followed by facial paralysis, that's a different scenario. But in this case, that's more like some traumatic stuff. But in this case, I'm thinking it is more transient in nature. Next one, otalgia can be caused by the following, except jaws, posterior teeth, oropharynx, trachea, neck. Do you want to answer this, anyone? Trachea, otalgia, pain in the ear or in the area close to the ear is called as otalgia. Jaws, posterior teeth, sometimes neck. I'm not sure how oropharynx is related, but probably oropharynx also. Some defects in oropharynx or some infection there might be causing that. So oropharynx. Trachea is something not related. It's very far away from that area, so might be not. So that's the answer for this question. In regards to HIV, which is the earliest finding, we've done this before. So everything is present, but reduction in white cells is the earliest finding. Anything that happens will happen after that. So anything that follows could be a reason of reduction in white cells, like infections. All those things will follow after the fall in the white blood count. Patient receiving treatment of oral cancer, what is incorrect? This is also a repeat question. Can suffer from dehydration, that is true. Can suffer from malnutrition, that is also true. Extract teeth in pain, probably not. I'll mark it and I'll read the others. Mucositis is always present in patients receiving radiation for oral cancer. Hyperbaric oxygen, can't remember the exact one. Hyperbaric oxygen is usually used in patients who are being treated for oral cancer, mostly in relation to radiation therapy. So definitely, if there's any, if that person requires any dental treatment, we will do the treatment followed by use of hyperbaric oxygen. So I'll go with the third one. You don't need to extract all teeth that are in pain. You might have to evaluate why there is pain. Is that pain a referred pain, or is it exclusively from the tooth? Usually, if there's a oral cancer diagnosis done, the patient will go through stages of treatment. So the first treatment would be to stabilize the oral cavity. If they are having decay, they will first get fillings. If they are having bad teeth, they'll first get those teeth extracted. And then as this is happening, they will start the treatment for oral cancer. So it doesn't happen in such a way that the patient starts radiation and then there's a large decayed tooth on one side of the. Usually it doesn't happen like this. So all the initial treatment covers those acute phase of treatment in the related to the teeth, as well as any other acute treatment, and then we'll go on to the treating the actual oral cancer. So extracting teeth in pain is not correct, because most probably they will not have any um, acute thing happening in their mouth. Now again, sometimes they might perio kind of pain, or others, but we will evaluate them. If there is a bad perio tooth, even before we start the treatment for oral cancer, we'll get it removed and then we will start. So all that thing is happening before itself. Typical features, this is also a repeat question. Typical features of Down syndrome do not include severe caries but minimal periodontal disease. They will actually have severe periodontal disease with or without caries. So that is wrong. All the others are correct. Which is not true in relation to the prescription of 5 milligram or 10 milligram diazepam for sedation. Patient commonly complains of post-operative headache. That's true. An acceptable level of anxiolytic action is obtained when the drug is given 1 hour pre-operatively. That's also true. There is profound amnesic action and no side effects. I don't know, maybe I'll mark it and I'll wait. Active metabolites can give a level of sedation for up to 8 hours post-operatively. That is very much true. Diazepam has active metabolites for a very long time. As benzodiazepine, the action can be reversed by flumazenil. That is also true. So I'll go with the third option. There is a profound amnesia. There's not profound, but there is mild amnesic action for this drug, and there are lots of side effects. So them saying that there is no side effect, that is not correct. So that would be something that is not true. Diazepam does have side effects, especially if given in higher doses than that is required. Endogenous morphine-like substance which can control pain is known as bradykinins, peptides, prostaglandins, serotonins, enkephalins. Uh, Here the answer is enkephalins. Endogenous means it's prepared by your body. So when in pain, your brain actually um, releases. I don't know the mechanism of how it releases, but your brain releases something which are called as enkephalins, and they actually act like morphine. They might not be as strong as morphine. They might not control the extreme pain, but it will control, say the pain is 8 out of 10, it will bring it down to 6 out of 10. And then the 6 should be managed by exogenous morphine or exogenous externally given pain medication. So endogenous morphine like substance is called as enkephalins. Maybe give it a bit of read, or there's a good reference down there. Give it more reading. I didn't go through all this. I don't know much about enkephalins. But if you don't know this answer, um, there is, say for example, obviously if you don't know this answer, you need to know what the other things are. So serotonins, when does your body release bradykinins, serotonins, and prostaglandins? Peptides are normal. That's not a pathology, so I'm not even going to explain about it. But bradykinins, prostaglandins, and serotonins are released in inflammation. So if the body is undergoing inflammation, then you have release of bradykinins and prostaglandins. They actually cause pain. So he's talking about morphine-like substance which will control pain. Definitely the first, third, and fourth options are wrong because they actually cause pain. Um, in that way, also you can answer this, but that is me being um, very cheeky. But enkephalins, they are morphine-like substances that are present in the body, released by brain when required, if in extreme pain. So um, yeah, if you see some videos and stuff, the people who still stand up and run in wars, even though their legs are broken, that is partly because the brain is giving lots of enkephalins, and there's this, they think that there's no pain, but they're in extreme pain. So next one. A patient presents complaining of stomach upset after starting course of antibiotic. We've done this before. It's just a side effect of the drug. I'm not gonna go into detail. I'll go to the next one. Which of the following adverse reaction of oral contraceptives is most common and is most serious? So oral contraceptives, the only thing that would be of greatest concern is thromboembolism. There is a possibility that it forms small blood clots. Not very common, but sometimes it might happen. When it happens, depending on that size of the blood clot, usually these blood clots travel in the body. They don't, say if it is a very tiny blood clot, they do travel all across the body. The largest vein is your leg veins, your deep vein thrombosis. How you would have heard about DVT. If the blood clot is large, it will usually cause DVT in that person. If the blood clot is very small, it might go all the way up to the brain and may cause a stroke. Now, this is very, very serious side effects of oral contraceptives. Very rarely seen, but good to know. Thromboembolism disorder. Next one, a patient who's been taking quantities of aspirin might show increased postoperative bleeding. This is also another repeat question. Synthesis of thromboxane A2 and platelet aggregation. So aspirin basically inhibits platelets. So that part, whatever that function that it needs to do, is not happening. Next one. Drugs contraindicated in monoamino oxidase: barbiturates, pethidine, local anesthetic with phelipressine, narcotic analgesics, salicylic acid. What do you think the answer is? Okay, nobody wants to answer this. Fine. Monoamino oxidase is basically used in depression. It is one of those drugs that is given commonly. We don't have absolute contraindications with monoamino oxidase inhibitors. Maybe if I have to pick one drug, I might pick pethidine, which is also called as meperidine. It's written here. Because it's written here, potential interactions between meperidine amphetamines include increased risk of hypotension, possibly leading to cardiovascular collapse, severe respiratory. Very rare. You're mainly because they both have CNS depression function. So if one drug is doing CNS depression, that's fine. But if both the drugs are doing same CNS depression, that might be a little bit of a trouble there. They both kind of work in this, the mechanism of action is similar. So its effect is doubled if you're giving two similar kind of drugs. Other than that, remaining all are not absolute contraindications. So you need to know what is an absolute contraindication, what is a relative contraindication. Relative contraindication is there are occasions where you can still use it. So not everyone in that group should not use monoamino oxidase inhibitor. Absolute contraindication is absolute contraindication. You cannot do it. If a person is allergic to latex, you cannot use latex. That is absolute contraindication. Most of the drugs, especially the mental health related drugs like antidepressants, anxiolytics and stuff, they do have a lot of interactions, but there's no absolute contraindication. Now this is also not absolute contraindication. It says exaggerated toxic response to meperidine are especially likely in patients. So he's not saying definitely, he's just saying likely. So again, from my perspective, such questions might not come in ADC because they're not going to ask you a question where the answer could be likely. They will definitely ask you questions where the answer is absolutely not likely. So it's good to know why there is an interaction between these two drugs. They both basically have similar, I'm not saying same, similar mechanism of action. They both do CNS depression. So that's why. Next one. The most characteristic allergic reaction to drugs, skin, I'll go with urticaria because the first one is angioedema or angioneuritic edema. That's not very common. Urticaria, definitely, yes. Which is not an effect of diazepam? Sedation, excitement, analgesia, hypnosis, general anesthesia. Sedation, yes, there is always sedation with diazepam. Hypnosis, yes, to some extent. General anesthesia, yes, if given in higher dose. I'll probably go with excitement and analgesia. There's no analgesic effect inherently from diazepam. And there's no excitement. The patient actually calms down, like immediately. Like in a little while, but yeah, they become very calm. They are sedated. They are kind of hypnotic, and they'll just sleep. So diazepam is more of a depressive kind of drug. So there's no excitement. Opioid analgesics reduce pain by the release of which naturally appearing product? Serotonin, histamine, enkephalin. So again, serotonin and histamines are not, they don't have anything to do with pain. So enkephalins. Next one. When taking monoamino oxidase inhibitors, which are contraindicated: barbiturates, local anesthetic with adrenaline, pethidine, acetyl salicylic acid. Now again, that's what I said. With monoamino oxidase inhibitor, there is no absolute contraindication. There is a relative contraindication in regards to local anesthetic with adrenaline. Like we've just done one MCQ before, pethidine. Barbiturates, again, they are anxiolytic drugs. So your monoamino oxidase, and they kind of have similar kind of mechanism of action. So in this MCQ, this is the answer. But again, I might see, I can tell you there's no absolute contraindication. But again, I want you to do a bit of research, so I could be wrong. So see how you go. But from what I know, local anesthetic with adrenaline is not an absolute contraindication. You will be a little bit aware, you will be a little bit vigilant when you have a patient on monoamino oxidase inhibitor. Most of the patients who take antidepressants, they actually don't know which drug they are on. They might just tell you, I'm on an antidepressant, and sometimes they won't be very happy if we ask more questions about it. I'm not saying that we shouldn't, but there is no absolute contraindication. I still use local anesthetic with adrenaline. Sometimes when I think they're taking more than 2 or 3 drugs related to depression and other stuff, that's when I will do plain LA. But there's no absolute contraindication. I've never had any patients complain or having any problem after this. But just for your information, if they ask you relative contraindication, I would probably pick this answer. But there's no absolute contraindication with this drug and local anesthetic especially. Which of the following penicillin are readily destructed by stomach acid? Methicillin, cloxacillin, phenoxymethyl, penicillin G. Anyone? Do you want to answer this question?
Penicillin G?
Yes, penicillin G. That's the reason why it's never given orally. It's always given IV because it is destroyed by the stomach acid. Good one. Next. Aspirin reduces pain by which of the following mechanisms? It is anti-inflammatory by the release of histamine. It blocks cyclooxygenase pathway. Anyone?
Blocks the cyclooxygenase
Second one.
Good.
pathway.
Do you guys know what is the cyclooxygenase pathway?
I think is one of the in clotting cascade or no. All right.
It's related to pain.
Analgesic.
So I thought it'll be easy if I open this picture. Can you see this image?
Yeah.
To explain. If you know this, let me know. I'm gonna skip. But if you don't know this, then so every time there is something like, for example, you have had a cut. So once that cut happens, first thing is your clotting mechanism happens. It'll stop the bleeding, whatever. After that, your phospholipase, the PLA2, is released into the body. And wherever there is phospholipase, that breaks down into arachidonic acid. Whenever you have a product in the body, that needs to break down and get excreted. If it is not getting excreted, then something is wrong. So this arachidonic acid splits or breaks down by two cycles. One is your LOX, LOX, LOX pathway, and one is your COX pathway, which is your cyclooxygenase pathway. This happens even in inflammation. It need not be a cut. It can be an infection or any inflammation, same mechanism. So your NSAIDs, so again, the LOX releases leukotrienes and eicosanoids. I don't know what eicosanoids are, but leukotrienes basically they cause allergy, like your asthma, like your rhinitis, all those things. So your runny nose, your inflamed sinusitis, your eyes, watery eyes. If you're in Australia, you would have heard about hay fever. Leukotrienes, they cause it. Your leukotrienes. That is one pathway. Another pathway is cyclooxygenase pathway. Now this one breaks down into prostaglandins, thromboxane, all those things. Now you don't need to know in detail what happens with all this, but your prostaglandins and thromboxane are the ones which cause lots of pain. Your NSAIDs act here. When someone is in pain, they still produce PLAs, they still produce arachidonic acid. Now all this arachidonic acid will break down into LOX when you're giving someone COX-2 COX inhibitor. So when you're giving NSAID, say suppose 10 parts of arachidonic acid is created, 5 parts will go through LOX, 5 parts will go through COX. Now you've blocked the COX, so all the 10 parts will go through LOX. That is how it breaks down. So in a person where you give NSAID, they might be producing more leukotrienes. They might end up having runny nose and lots of those stuff. This is exactly why you don't give what is that drug that you don't give in ibuprofen? You don't give ibuprofen for an asthma patient because it basically blocks this cycle, and then all the arachidonic acid breaks down through LOX, and the more leukotrienes present, the more asthma effect they'll have. So they'll end up having severe asthmatic effect if the person is. That is the reason why you don't give ibuprofen. Ibuprofen again is an NSAID. It blocks this cycle. So we want that arachidonic acid to go through LOX as well as COX. This NSAID acts here, whereas your COX-2, have you heard of COX-2 inhibitors? They act here. So the COX-2 inhibition is done, but they still have COX-1. And your steroids, they basically act here. So when you give a person a steroid, they're not producing arachidonic acid at all. They only have phospholipase, but they're not producing arachidonic acid. So they're not producing leukotrienes. They're not producing prostaglandins and everything. So NSAID and your steroids, they act here. Okay, cool.
Thank you.
No problem.
Yes, thank you.
No problem. Go back to the MCQ. Next one, in regards to chlorhexidine mouthwash, is anionic, used in 0.02% concentration, used in 0.12 concentration, penetrates the gingival crevice. What do you think?
Used in 0.12.
Yes, perfect. Sometimes used in 0.2% in endo, like if we do endo irrigation and all. It can be used in perio as well, but more commonly used in endo irrigation, 0.2%, but not 0.02. In regards to benzodiazepine, increases REM sleep, has a hangover effect because of active metabolites, includes carbamazepine, can be used safely in children as it achieves reliable effects. What do you think is correct in regards
Include carbamazepine. Third
Do you
one.
do you
Carbam-
think?
It's not used safely for kids.
That is, yeah, it is not used safely in kids. That's why
Yes.
this is wrong. I think it's
First
this one.
has hangover.
Has hangover effect because of active metabolites. Carbamazepine, I'm not sure actually. That's a good question. I'll go through once. Yeah, I don't know. Maybe not. Maybe it is not part of benzodiazepines, but there's no harm in just seeing what kind of drug carbamazepine is. I'm sorry, I can't remember. It definitely does not increase REM sleep. It has got nothing to do with your REM sleep. It cannot be used in children. We have to be very careful when giving it to children. So that's also not correct. I'll go with the second option here, but I will review this carbamazepine definitely. Okay, patient with morphine coma. What is the medication of choice to reverse its act? Bradykinin, epinephrine, amphetamine, naloxone. Antagonist for morphine is naloxone. It actually, if a person has taken too much morphine, they give naloxone, and the morphine gets excreted. It binds to morphine and it gets excreted as soon as possible. Why are streptococci resistant to penicillin? They produce penicillinase.
Just
That is,
for the benzodiazepine, the drugs they are lorazepam, oxazepam, and diazepam.
diazepam.
Yes, there is no cara.
Yeah,
Yes,
carbamazepine. Yeah, it's.
because I'm taking notes for
Oh
the
yeah,
drug.
sure,
For
sorry.
so
Yeah.
it's not included. Yes, you are right.
Yeah, I thought so too. It's carbamazepine. I think it's used in trigeminal neuralgia, if I'm not wrong. Is it correct?
I can't remember, but I have here, I took notes for all the drugs.
Yeah.
Let me check. Okay, we'll check it after.
Yeah, sure. Good. Thank you for letting us know. Yeah, thank you. So this is the next one. Why is streptococci resistant to penicillin? It produces penicillinase by itself, so it kind of neutralizes the function of penicillin. That's why it is resistant to penicillin. Next one. Which drug may cause respiratory depression? Barbiturate, aspirin. We'll go with barbiturate. Yeah, barbiturate. Respiratory depression. Aspirin has got nothing to do with that. It might, it might interfere with platelets, but not respiration. Next one. Why do you give atropine in general? To reduce the salivary secretion, to relax the patient, to enhance the action of LA. I don't know about this. Definitely atropine is not used for that. So I'll go with reduce salivary secretion. Next one. Halothane anesthetic by hepatotoxic reaction, nephrotoxic reaction. I'll go with hepatotoxicity. Normally when liver gets toxic, at some stage even your kidneys start getting affected. So, but still halothane solves hepatotoxicity. In regards to metronidazole, it is effective for the treatment of ANAG. It is not used to treat deep oral infections. First one, yeah. Even the second one is correct if it is used for deep oral infection. Sometimes we do use if there's abscess or swelling, stuff like that. We do use metronidazole. So that is again called as deep oral infection, but definitely used for ANAG. The mode of action of drug may be defined as how it produces its action, effect of the drug. I'll go to the first one. Mechanism of action of the drug. It's also called as mechanism of action or mode of action. How it produces its action. A patient indicates that he takes methyl dopa. He is being probably treated for hypertension, angina pectoris, myocardial infarction. What do you think is the answer? Definitely not myocardial infarction. Probably not even. I'll go with hypertension. Yeah. I've never heard, not a very commonly heard antihypertensive drugs, but yeah, methyl dopa for hypertension. Benzodiazepine and diazepam in 5 to 10 oral mg oral dose used for oral sedation in dentistry does not give a good analgesic effect if given 1 hour prior to dental sessions. Would be reversed by flumazenil because it is a benzodiazepam. Post-operative headache. There is a profound, okay, so it's basically the same question. That's the answer. There is no profound amnesic. There is mild amnesia, and no, that's not correct. So it's not correct in this question. Next one. Use of inhalation, general anesthesia, halothane should not be less than 5%. Oxygen must not be less than 30%. So when we are giving inhalation sedation, it's always 30 to 70. So whatever drug, the other drug that we're using, mostly nitrous oxide, that'll be 70%, and oxygen will be 30%. So oxygen must not be less than 30% is correct. The elimination of half-life of diazepam in the range of 2 to 5 hours, 5 to 12 hours, 12 to 30 hours, 30 to 48 hours. I'll go with this because they say that it's usually 24 to 48 hours elimination time. So yeah. Again, a little bit tricky question because 96 hours is too much, but 70 is quite few days. Anyways, I'll still stick with 30 to 48 hours. Next one. In regards to paracetamol, yeah, there is there's so many studies saying that chronic use of paracetamol might cause liver damage. So that's true. Most common drug for dental pain. Over-the-counter NSAID, over-the-counter paracetamol, prescribed only NSAID, prescribed only paracetamol. What do you think? Most common drug of dental pain, drug for dental pain.
Over-the-counter NSAID.
Over-the-counter. I don't prescribe any pain medication when I'm doing extractions because I just tell the patient to go buy over-the-counter pain medication. Can be usually for extractions and stuff, NSAID, paracetamol would not be enough. So yeah, dental pain, any sort of pain, it's only over-the-counter. If the patient comes back and tells me that's not working, that's when I will go with either prescribed only paracetamol. Prescribed only paracetamol is not just paracetamol. It contains more than paracetamol. That is why we are prescribing it. It will be in combination with codeine, depending on the dose. That is prescribed. You cannot get codeine over the counter, so you have to prescribe it. But usually it is over the counter NSAID. Percentage of penicillin allergy is very rare, 5%, 15%. Sorry?
5%.
5%. Very good. Yeah, 15% is a little bit too much. Not also, again, this 5% in allergic reactions are not anaphylaxis. Anything from urticaria to anaphylaxis is that falls into this 5%. Lithium citrate is used for treatment of mild depression, mild anxiety, coping disorders, deep endogenous depression, lithium insufficiency. Lithium is usually used for deep endogenous depression. That's the drug of choice. So for milder cases, it's more milder medication. So there's nothing called as lithium insufficiency. How long is amoxicillin? We've done this before, 5 days. Go to the next one. What is incorrect about topical corticosteroids? It is locally immunosuppressive, doesn't have systemic immunosuppressive effects. Skin creams cannot be given intraorally, can be given alone in oral infections, cannot be given in case of lichen planus until diagnosed. Of all the options, I think that doesn't make sense for me, because you cannot give steroids in any kind of infection. So that's probably the incorrect sentence of these. What is incorrect about corticosteroids? Incorrect. Okay. Betamethasone. Sorry, I clicked it accidentally. Hydrocortisone acetate 1%. Betamethasone. Any of ABC can be used indefinitely. Cannot be given in case of lichen planus until diagnosed. That's true. So I'll go with the fourth one. Cannot be used indefinitely. There are specific indications for these. So you need to, depending on the case and the person and the medical history, we select one of these. Which of the following is true in regards to high-risk patient? 0.1 ml of blood from hepatitis B carrier is less infective than it's actually more infective. Hepatitis B is more infective, more contagious than HIV, so that's not correct. Probably that is correct. Level of virus is similar in the blood and saliva. Not correct. It's more in the blood. Level of virus in the saliva is not significant for hepatitis B patient. That's also not correct. It is very much significant. The presence of Hep B core antigen in the blood means that active disease is not present. I have another cheat sheet about hepatitis B. How do you interpret the serology results? But in this MCQ, I think I'll go with the second option. That's true. That's not correct. The presence of hepatitis B. I'm going to go through this CDC document, and I'll ask you to, download it or save it on your phone somewhere, because it's a very interesting one. Next one. Your employer, in an attempt to update office sterilization procedures, infection control, thing has been recently updated. Here, this is the answer, but I would contradict that. But anyways, that's the answer. I have to go through infection control, that journal once again to give you correct answer, but I'll go with this for now. The most potent vericidal properties, another format of the same answer, indicate which of the following has vericidal properties: sodium hypochlorite, chlorhexidine, glutaraldehyde, alcohol, quaternary ammonium. Anyone? Do you want to answer that question? It's glutaraldehyde. Alcohol 70%. Probably you need a little bit more percentage to kill virus. Maybe 100%, but glutaraldehyde has vericidal properties. What is true about disinfectant solution, it destroys all pathogens? No. It reduces the number of microorganisms to a non-infective level? Probably not. It kills all pathogens but not spores. I go with this. The function of disinfectant is to kill pathogens, but it doesn't do anything to the bacterial spore. So it can still get infected. That is why the second option is not correct. So it reduces the number of microorganisms, that is correct, but not to a non-infective level. It can still be infectious. So that's why this option is not correct. Next one, what is the mode of action of autoclaving moist sterilization? Moist heat sterilization, protein denaturation. So I'll go with the second option, protein denaturation. That is what actually kills that bacteria. So all the protein in their cell structure is destroyed. Steam under pressure sterilization is the best method to kill microorganisms. How does it work? Coagulation of plasma protein, dehydration of DNA. I'll go with plasma protein. That is again protein denaturation. That is what kills the bacteria or the microorganism. Which of the following does not carry a risk of infection from hepatitis B patient? Surface, S stands for surface, AG stands for antigen. Surface antigen or surface antibody. So surface antibody should be present in your body to call that person they don't carry the risk of hepatitis B. So technically they're vaccinized. So I'll go with this option, and I'll just, yeah, you have another reference here, but this is a very good one. So it's from CDC. It says interpretation of hepatitis B serological test results. So say, for example, you please go through the article completely, but I'll just go through the table. Say if you have a person, you do a blood test and that's your surface antigen, that's your antibody. So anti is body. So your core, there is a core antibody and there is a surface antibody. If none of them are present, that means this person is susceptible to infection. So if this person is exposed to hepatitis B, they will get infected because they have never been infected before and they are not vaccinized. Say if a person has, there's no surface antigen, it's negative, but core antibody is present and surface antibody, both core and surface antibody are present, positive and positive. They are immune because they would have had previous infection. So previously they got infected by hepatitis B. So they exhibit surface and core antibodies. Now, how do you differentiate a person from being immunized or getting previous infection? So in a person who's immunized, say I'm immunized to hepatitis B vaccination, I will not have a core antibody, but I will only have surface antibody. So if you want to know, or if you want to put someone as immune to hepatitis B, like they would have taken a vaccine, then they will exhibit only surface antibody, not the core. And so on and so forth. You can just go through acute infection, chronic infection, and you can just download this sheet. It's very good. It helped me a lot. It'll answer questions like this. So which of the following does not carry a risk of infection? Is surface antibody, because he's immunized. That's it. Simple as that. Next one. Which of the following procedures will not achieve sterilization? So anything from 115 or 118 above, I will call it sterilization. So 160, yes. 100, probably not. Autoclave, yes. Usually it's 134, but I don't know why they've put it as 121 here. Dry heat 177, yes. All of the above can achieve. No, that's not correct. So this one, just by boiling, you're not going to achieve sterilization. So that's that. I've got a few more minutes. What I'll do is I'll continue with the third set of MCQs. I'll just do maybe 10 of them. What is the purpose of making a record of protrusive relation, and what function does it serve after it is made? To register the condylar path and to adjust inclination of the incisal guidance, to aid in determining the freeway space and to adjust inclination of the incisal guidance, to register the condyle path and to adjust condylar guides of the articula so that they are equivalent to the condylar paths of the patient. So I'll probably go with this because they're talking about both condylar path and condylar guides, which should resemble the one in the patient. So that's why we do protrusive, retrusive, and all the other jaw relations. Next one. The main factor controlling the decision to increase the occlusal height of teeth for extensive oral reconstruction is whether the interocclusal distance will be physiologically accepted after treatment. There may be sufficient tooth bulk in the abutment teeth for proper retention of the crowns. At least 2/3 of the original alveolar process will remain for adequate periodontal support. Aesthetic appearance of the patient. Before any of this, I will probably go for physiologically acceptable limit. So just by increasing occlusal height, it's not a very easy thing. The patient should be able to accept that increased height. Otherwise, they'll come back with pain or soreness of the muscle. So it's very important to understand the physiological limit of the patient. Next one. In planning and construction of a cast metal partial denture, the steady cast facilitate the construction of custom special trays, minimize the need of articulating, provide only limited information about inter-ridge distance, which is best assessed clinically, can be used as a working cast when duplicating facilities are not. I don't know, I'm really confused with this question. Yeah, maybe sometimes they use steady cast to make special trays, your primary cast, but it can also be used to make a working cast, not the secondary cast, but the primary one when duplicating facilities are not available. Even that is maybe correct. I'm not sure. Again, a very tricky question, very half mentioned question. Periodontal damage to abutment teeth of partial denture with distal extension can be best avoided by applying stress breakers, employing bar clasps, maintaining tissue support of the distal extension, clasping at least 2 teeth for each edentulous area, maintaining the clasp. Always distal extension means that there's no teeth beyond that. So periodontal damage in anterior teeth is very, very commonly seen, but this can be avoided by maintaining very good tissue support. So good distal extension, the flanges and everything should be very well supported to reduce that periodontal stress on the anterior teeth or abutment teeth. Next one. Which of these muscles may affect the borders of mandibular complete denture? Mentalis, lateral pterygoid, orbicularis oris, levator angularis, temporally. Temporal and lateral pterygoid definitely not involved. Orbicularis oris, again, very close to the lower denture, but not involving denture. Levator angularis is nowhere related to denture. So I'll go with mentalis in this question. That is the closest one that I can pick off from the list. Jaw relation of an edentulous patient has been established. The maxillary cast has been mounted on the articula without a face bow. You decide to increase occlusal vertical dimension by 4 mm. This will necessitate opening of articulator by 4 mm, a new centric relation to be recorded, a change in the condylar guide settings, and increase in the rest vertical dimension. I'll probably go with a new centric relation. Definitely need a new centric relation if you're trying to increase by 4 mm. Otherwise, again, it will not be physiologically accepted. Then again, patient might have problems. So a new centric relation would definitely be required in such a case. Following extraction of the molar teeth, the ridge height is lost more from the maxilla than the mandible. The maxillary ridge will get more bone loss from the palatal aspect of the than the buccal. The mandibular arch is relatively narrower. Compared to the pre-resorptive state, the mandibular ridge will lose more bone from the lingual aspect than the buccal. Probably go with the fourth. Yeah. Did you say last or first?
I said last.
Good. Okay, next one. Which of the following is a major disadvantage of immediate complete denture therapy? Trauma to extraction site, increase the potential of infection, impossibility for anterior trine, excessive resorption of. They're all they're all kind of disadvantages of immediate denture. But the main thing would be impossibility for anterior trine. So there's no trial. Patient might not like it or whatever it is. There's no trine phase, so that can lead to a lot of problems. Apart from that, you do have the other things also might happen in an immediate denture. Next one. What is the main purpose of using stress breakers? To distribute the load between teeth and ridges, to distribute the load between clasps and the face end of the saddle. It relieves the abutment teeth of occlusal load that may exceed their physiological strength. I will go with the third one. Stress breakers mainly manage the occlusal stresses, especially on the abutment teeth. So, stress breakers, function of these stress breakers. Next one. Which is more retentive form for anterior bridge? 3/4 partial veneer crown, class 5 inlay, pinlay veneer, class 3 inlay with pins. I'll probably go with 3/4 because it's kind of encircling almost the entire tooth. So that'll definitely have more retentive form compared to the others. I'll stop here for today. Abdi is waiting there. I'll just stop my screen share. If you have any questions, you can ask me, or else I will go have my dinner.
For carbamazepine, it's anti-epileptic and hyperplastic for the gum.
Oh, okay. That's good to know.
Okay.
All your anti-epileptic drugs cause gingival hypertrophy.
Yes. Yes.
Like your Dilantin sodium, drug-induced gingival hypertrophy. There were questions about how you treat a gingival hyperplasia or hypertrophy. Sometimes surgical, but mostly we will just conservatively remove plaque and calculus, so that should relieve the symptoms. Good.
Yes.
Thank you for letting me know.
Thank you.
Okay, so